Hi everyone, welcome back to my channel. Today we are going to discuss about pneumonia. Pneumonia was the leading cause of death all over the world over the centuries. And even still, with the new pandemic of corona, we all knew that it is still one of the leading cause of morbidity and mortality all over the world. Ladies and gentlemen, I am Dr. Zakir Hussain. I am a pulmonologist and critical care specialist at Bahrain Specialist Hospital. Pneumonia is defined as acute infection of pulmonary parenchyma. Depends on the place where they acquired. It is classified as a community-acquired and nosocomial pneumonia. Community-acquired pneumonia is the pneumonia which is acquired outside of the hospital, in the community, in the house, in the workplace. Whereas nosocomial pneumonia is acquired inside the hospital setting. This classification is important to start the antibiotics. As we all know that nosocomial means they are usually acquired by the drug-resistant bugs, drug-resistant bacteria. So this classification is very important. And nosocomial pneumonia is further divided as hospital-acquired pneumonia, ventilator-associated pneumonia, and healthcare-associated pneumonia. Hospital-acquired pneumonia is defined as acquiring pneumonia more than 48 hours after hospital admission. And ventilator-associated pneumonia is which is acquired after 48 hours of endotracheal intubation, and healthcare-associated pneumonia is when patient get infection from the healthcare facilities like nursing homes or dialysis centers. Recently, they changed the word healthcare associated pneumonia because of their multiple use of broad spectrum antibiotics, overuse of broad spectrum antibiotics just because they come from the nursing homes or dialysis centers. So now they are classified as the same community acquired pneumonia to prevent misuse of broad spectrum antibiotics. Pneumonia is further classified as mild, moderate, and severe based on the clinical symptoms and also based on the hypoxia. In severe, it is classified as ARDS, and based on the acute respiratory distress syndrome, based on the PaO2 by FiO2 ratio, it is classified as further mild, moderate, and severe. And the risk factors for the pneumonias are the age, both extremes of age. Elderly people more than 65 years and above, they are more prone to get infections, more prone to get pneumonias. Whereas the children less than 5, predominantly less than 2 years, they are more prone to get pneumonias. And patients with the chronic comorbidities like chronic lung diseases, COPD, and bronchiectasis, these people are more prone to get pneumonias. And chronic diabetic patients, because of low immunity, they are prone to get infections. And CKDs and all other chronic kidney disease patients, stroke patients, and chronic heart failure patients, they are prone to get pneumonias. And patients with the low immunity, especially HIV, depends on the immunosuppressive levels like a CD4 count, we can divide into pneumonias. And also in patient who is on immunosuppressive medication like post-transplant, the first month will be like a normal community acquired pneumonias, whereas after 1 month they are prone to get pneumonia in immunocompromised patients. That we are going to discuss later in next presentation about the pneumonia in immunocompromised people. And based on the impaired airway protection because of substance abuse like overuse of alcohol, becoming unconscious, unprotected airway, this leads to aspiration pneumonias. And patients living in a crowded living conditions like in prisons or in the refugee camps or in military camps, they are prone to get pneumonias. And especially we see recently with these pandemics and also a lot of viral epidemics that happened with the influenza recently, post-influenza, we are seeing patients getting secondary bacterial infections. And pneumonia is further classified as typical and atypical pneumonia. The common typical organisms like Streptococcus, Staph aureus, and these bugs cause typical pneumonias, whereas atypical pneumonia is caused by the rare organisms like Mycoplasma, Legionella, Chlamydia, and all these bugs cause this atypical pneumonia. The presentation radiologically will be interstitial mostly, whereas a typical pneumonia we see classical of alveolar and lobar pneumonia patterns with a unilateral pneumonia in typical pneumonias, whereas in atypical they will be having bilateral pneumonias like viral infections we see, bilateral basal infections. And atypical pneumonia we see commonly in immunocompromised patients, whereas typical pneumonia is common in immunocompromised also, and we see even in immunocompetent people also having typical pneumonias. The classical thing of typical pneumonia is there are classical pulmonary symptoms, and symptoms will be more than the signs, whereas in atypical pneumonia, their extrapulmonary symptoms will be more, and they have more signs than the symptoms. Same like recently we are hearing a lot of walking pneumonia in China with the mycoplasma pneumonia. So they don't have much symptoms. They don't have cough. They get fever and other symptoms, but not respiratory symptoms. And incidentally, they can find that X-ray have a lot of pneumonia patches. Where on the auscultation, we definitely see crackles in these people. So that's why the signs will be more than the symptoms in atypical pneumonias. The common bugs that cause typical pneumonias are Streptococcus and H. influenza, Moraxella. These are common in COPDs and other people. With the advent of new pneumococcal vaccine, we are seeing the Streptococcus is losing its top place soon. We are seeing less of Streptococcal pneumonias with the pneumococcal vaccine, both polysaccharide and conjugative vaccines. A lot of people are taking nowadays. So things are improving with the streptococcal pneumonia, whereas H. influenza, Haemophilus influenza, and Moraxella and other things are still there. Enterobacteria and E. coli will cause mostly aspiration pneumonias, and whereas atypical pneumonia, the classical one are Mycoplasma, Legionella, and Chlamydia. Especially Chlamydia psittacii is very common, and in rickettsia like Coxiella burnetii, Q fever, these all these kind of things. And the diagnosis is classical blood test for CBC and CRP. You see white blood count will be on the higher side and with the neutrophil predominant, whereas CRP also suggestive of pneumonias and blood cultures in certain patients. The sputum is the diagnostic of choice in pneumonias. The sputum, early sputum, sputum and sputum gram stain and cultures, and also sputum for AFB also to rule out other type of tuberculosis. And some people in atypical pneumonia, we don't get sputum. They have dry cough or pneumonia with in immunocompromised patients. We always plan to go for bronchoscopy to get early diagnosis of the bug. And the ball is more sensitive, and even protectus breast specimen is more sensitive than that one. 10 to power of 3 colony count will suggest you will differentiate from contamination with real bug. So PSB is more sensitive. Even lung biopsy is 100% sensitive and specific for finding the pneumonias. And with the new onset of multiplex PCR, we are seeing a lot of people, a lot of hospitals, they are doing multiplex PCR, which is a rapid test, and which will be within 4 hours we get the diagnosis and we get the proper treatment and less unnecessary use of broad spectrum antibiotics. And imaging, X-rays and CT scans are always helpful in diagnosing pneumonias. This is one of the busiest slide, and it is very important slide. See, based on the risk factors and based on the location and work exposure, we can identify the bugs, especially patients with exposure to the birds. We have to rule out Chlamydia psittacii, and patients with exposure to the bat and bird droppings like certain caves, and these people we have to rule out Histoplasma capsulatum, the fungus. And patients with the exposure to rabbits, tularemia or Francisella tularensis. And in HIV patients, depends on the CD4 count, we have to start on proper and appropriate antibiotics. And patients with a recent hotel or cruise ship visit, we have to think about Legionella, and depends on the geography. Travel to the residents in southwestern United States, we have to think about fungus like a coccoid mycosis, or in Burkholderia pseudomonas. In African areas, we do see Pseudomonas pseudomallei, causing melioidosis. And IV drug abusers, we had to rule out infective endocarditis or Staphylococcus under these kind of bugs. And also alcoholics, we have to think about Streptococcus and other things. The scoring of pneumonia is very important. In the scoring, it is helpful in the emergency room to differentiate between mild, moderate, and severe, whether he goes outpatient or he will be treated in inpatient or in the ICU. These are the basic and easiest scoring. The curve 65, which is confusion, which gets 1 point, and urea more than 40 mg/dL or 7 millimole, and respiratory tachypnea and low blood pressures and age more than 65. If we don't have the urea also, still this score is valid with CRB 65 score. And based on the score, we have to differentiate where we can treat the patient, either outpatient or inpatient or in ICUs. And this is one of the best score, but unfortunately it requires a lot of parameters. We can decide after 1 hour of 2 hours of emergency visit. Like pneumonia severity index, there we get all the details like age, and males will be more prone and females will be less than -10. We have to differentiate, and people from the nursing homes, we have to add another 10, depends on the comorbidities. We have to add the points, and depends on the clinical examination, the fever and blood pressures and all those things. We have to add extra points, and based on the labs like sodium and arterial pH and all those low pH, such of acidosis and all those things, and oxidation. This helps us in score less than 90 will be treated as outpatient. Score more than 90 will be treated as an inpatient. Score more than 130 needs ICU care. And this is also one of the useful score, which is commonly used in differentiating between ICU versus ward cases. It is a smart cop scoring, same consists of blood pressures and multilobar chest X-ray involvement and low albumin and tachypnea, tachycardias and confusions and oxygen levels, and also the acidosis in the blood gases, metabolic acidosis, suggestion of sepsis. So it depends on that whether patient require intensive respiratory and vasopressor support. We can differentiate by the scoring. These all scores helps us in identifying where the patient goes from the emergency room, whether he goes to the ICU or he goes to the ward. Instead of each doctor has their own way of deciding where to admit. So, and also the scoring plus clinical symptoms, we had to take a call on that. And this is the recommendation by the IDSA and ATS, which strongly recommended to empirically to start with the beta-lactam plus macrolide combination for all the patients with the pneumonia, with the patch in the lung, not for simple lower respiratory tract infections. It is for the patients with the pneumonia in the X-ray and clinical symptoms. We had to start always combination therapy. Even with non-severe pneumonia or also with severe pneumonia, we had to start this combination therapy. And this is the company slide, and they have done the head-on studies. Clarithromycin plus beta-lactam, they recommend strongly for the sake of community-acquired pneumonia. And in the 2007 and 2019, the ATS and IDS guidelines, there was a difference in recommendation. Initially, they recommended both beta-lactam macrolide plus or minus, or you can go with the beta-lactam plus fluoroquinolone. Whereas in 2019, they have strongly recommended, they are in favor of going only with beta-lactam plus macrolide combination because of the robust data that they had. And this is the also company study. They have shown that clarithromycin plus beta-lactam has better mortality rate than azithromycin plus beta-lactam, or fluoroquinolones plus beta-lactam, or monotherapy with a beta-lactam. So always go with a macrolide plus beta-lactam combination for most of the patients. And azithromycin, I have seen, I think with the COVID and a lot of things, there was a lot of misuse of azithromycin over the years for simple lower respiratory, or even with the flu or even with the coronavirus also. Azithromycin has become national drug in many countries. So with that, we have seen a lot of resistance for azithromycin nowadays. So preferable always when there is a pneumonia in the X-ray and clinical symptoms, always start combination with the beta-lactam plus clarithromycin. And they have proven also that there is a azithromycin has significant resistance because of the longer half-life and lower potency than the clarithromycin. Let's discuss about the important atypical pneumonia, and notorious one that we see a lot of cases of mycoplasma. Mycoplasma pneumonia is the smallest free-living organism. It is an atypical organism, and it doesn't have any cell wall, so we cannot able to stain them. So there is no role of gram stain in these pneumonias. And as it doesn't have a cell wall, there is no role of beta-lactam antibiotics. As beta-lactam antibiotics, the mode of action is inhibition of the cell wall synthesis. So when there is no cell wall, no role of beta-lactam antibiotics. So that is the reason the IDSA and ATS is recommended in most of the patients with a community acquired, whether we don't know whether it's a it's a typical or atypical organism. That is the reason they always suggested to go with the combination therapy of beta-lactam plus macrolide, as macrolides are the drug of choice for atypical bugs. And the spread is from human to human, the droplet spread. And very commonly outbreaks will be seen in the hostels or in the prisons or in the refugee camps. The incubation period is from the first week to 4 weeks, and it has multiple pulmonary manifestations like a simple upper respiratory infection, like patients develop with the cough, throat pain, running nose, sneezing, and ear pain is one of the classical of upper respiratory symptoms of mycoplasma. Whereas in the pneumonias, we do see fevers from low grade to high grade, and also significant sore throat, significant cough. And one of the classical thing of mycoplasma is new onset of wheezing. That was not there even without a history of asthma. We do see wheezing in patients with mycoplasma. And same like other viral infection, we do get all headaches, malaise, and significant pleuritic chest pain. A lot of symptoms will be seen. The extra pulmonary manifestations are more than the pulmonary manifestations with the mycoplasma that you should be aware of. The common extrapulmonary manifestations are from the skin. It's the erythema multiforme that is commonly seen on the shins, and whereas urticaria and some people have other kind of rashes also. Main hemolysis is very commonly seen in hematological manifestations of mycoplasma, and cold agglutinin disease, and also CNS manifestation, commonly meningitis or encephalitis, or sometimes peripheral neuropathy also seen. Very rarely we see GBS post mycoplasma. And important thing is the cardiac abnormalities that we see a lot of patients with myocarditis and pericarditis, and also some people with the conduction abnormalities also seen. The commonest extra GI manifestations are diarrhea. Especially we see a lot of patients coming with diarrheas, and hepatitis and transaminitis. All these things are very common with mycoplasma. And some people do have septic arthritis. We have seen patients with COVID-19 and also mycoplasma pneumonia combinations also. And labs, common labs that we do for these patients with mycoplasma, CBC, CRP, important is direct Coombs test. Cold agglutinin test is very important to identifying this one. And even this IgM for mycoplasma also helpful. And now nowadays we are doing a lot of molecular testing like PCRs and multiplex assays that helps us in diagnosing this one. Chest X-rays will always help us in identifying the bilateral pneumonia patches. And this is the imaging of this mycoplasma pneumonia. If you have seen classical pneumonias in bilateral, that is classical of mycoplasma. The treatment here, drug of choice or macrolide is the drug of choice for atypical pneumonias. As all atypical pneumonias, macrolides, tetracyclines, and fluoroquinolones. All these three drugs are drug of choice. So among the macrolides, erythromycin, azithromycin, and clarithromycin, we have seen a lot of resistance with azithromycin that I mentioned previously, and erythromycin has some side effects. So it is used as a prokinetic in most of the ICU patients, and all these macrolides will cause altered in GI motility. That's why they may cause diarrhea, severe gastric issues. That's why we have to ask them to take after 1 hour of food. The mechanism action is it inhibit protein synthesis by inhibiting a RBA ribosome 50S subunit. And the important consideration, we should be careful with the QTC in elderly people on cardiac medication. QT prolongation is very common in macrolides and fluoroquinolones. And cholestasis and hepatic dysfunction also common. Somebody with myasthenia gravis always try to avoid these drugs as they are notorious to exacerbate myasthenia crisis. And second group commonly used in all atypical pneumonias are tetracyclines. The common thing that we prefer to go with doxycycline and minocycline. And it also inhibits protein synthesis by binding to RBS 30S subunit. And the important consideration, especially with the doxycycline, is erosive esophagitis when somebody is taking long term and significant gastritis. That's the reason we ask them to take uh, uh, after food. And second thing, you should be careful to should not lie down for half an hour, up to half an hour after eating this doxycycline, because the reflux will cause significant gastritis and photosensitivity and hyperpigmentation, especially in the kids. Tooth discoloration is very common with the doxycycline, so you should be little careful in using these medicines in children. Fluoroquinolones are third important drug of choice for all atypical pneumonias. The ciprofloxacin, we do see a lot of resistance everywhere in the world, and levofloxacin, moxifloxacin we are using a lot. Among them, especially in countries where TB is endemic, like Indian subcontinent, African subcontinent, in Russian countries, we try to avoid using fluoroquinolones being a pulmonologist, because this line of drug is used for second line treatment for multi-drug resistant tuberculosis. So try to preserve these molecules for the tuberculosis patients. So whereas in other countries we can still use it if it is there is no other option for other alternative drugs. And it also inhibit protein synthesis by inhibiting DNA synthesis there, and it is also notorious to cause QT prolongation, and also similar like other drugs, it will also exacerbate myasthenia crisis. And one of the important classical problem with the fluoroquinolones are tendon rupture or tendinopathy. This is very common. You should be careful in giving this medicine for elderly people. The second most common atypical bug that we commonly see is Legionella. It is notorious to cause both community-acquired pneumonias or nosocomial or hospital-acquired pneumonias. It is commonly seen in water supply in large buildings, and especially like hotels and hospitals and apartment buildings. And also we see in certain saunas, spas and steam bath area also. And have seen 2-3 cases patients coming from the saunas and steam bath areas coming with pneumonias after the spa treatment and all those things. And we no longer use heated humidifier oxygen in ICUs because of this bacteria getting contaminated in those things. The infection spreads by the aspiration of these bacteria, either by aerosol inhalation or all those things, which leads to notorious Legionnaires disease. You would have seen this hotel. This is the classical there was an outbreak of Legionnaires disease in 1970s. This is a hotel at Stafford Hotel in Philadelphia. There, the word Legionella or Legionnaires disease has come. Legion means the group of army officers. In 1976, there was a meeting of army officers in that hotel in Philadelphia, where they all acquired, by staying there, they all acquired infection. Almost 182 army officers got severely affected. Among them, 39 have died, unfortunately. And from then, it is labeled as Legionnaire's disease. And later, they found that they isolated Legionella pneumophilia from the water of air conditioners in the hotel. So, with the history of recent visit to hotels or any cruise ships or any of these spa and saunas, we have to suspect Legionella. The common symptoms that we come across are fever, cough, dry cough. Mostly of the patients have dry cough and breathlessness, and usually the symptoms starts after 2 to 10 days of exposure to the contaminated water. It has a high mortality. Pneumonia with this disease has a high mortality, and it leads to moderate to severe pneumonia. Especially in the immunocompromised patients, we do see severe pneumonia in this. There's another type of Pontac infection, we call that Pontac fever with the Legionella, which consists of fever, headache, chills, and myalgias, and more of GI symptoms of nausea, vomitings, and diarrhea. This is known as Pontac fever. And these are the pulmonary manifestations, whereas extrapulmonary manifestations of Legionella are classical of GI symptoms. Lot of patients come with the diarrhea and vomitings and these symptoms, and later on incidental finding, we see that they cough and we see the X-ray, there will be significant patch. So thus we have identified a lot of cases of Legionella pneumonias, people coming from the saunas and spas. And hyponatremia is the classical thing that we see with hyperkalemia. Some people do have hematuria, and elevated transaminases are very commonly found in this. Most of these patients will have high CRP numbers and all those things. The classical thing that we used to differentiate patients, they fail to respond to monotherapy with the beta lactams. Still, a lot of the physicians, they start with monotherapy with beta lactams in most of the pneumonias. So patient not responding to beta lactams, we had to suspect atypical pneumonia always. The diagnosis with the PCR is the classical. It helps us in rapid diagnosis of this test. We can get faster value within 4 hours, 3 to 4 hours, depends on the labs, and urinary Legionella antigen testing. But unfortunately, it identifies only serotype 1 only. We cannot identify other other types of Legionella, but it also helps. This is the only bug that we can identify from the urine Legionella antigen testing. And blood cultures and all those things also will help us in finding this one. The treatment, as I already mentioned in the previous slides, macrolides are the drug of choice, and second comes tetracyclines with the fluoroquinolones. Let's discuss about psittacosis. It's one of the beautiful bird that cause very dangerous disease. So Chlamydia psittaci is the bug that causes bird fever, commonly known as bird fever, or psittacosis or ornithosis. It is chlamydia is an obligate intracellular bacteria, which is this chlamydia pneumonias we see a lot. Psittacosis we see in US, UKs, and Europe, and we see a lot in Middle East also. And previously it used to be only 1% of community acquired pneumonia because of lack of routine testing. But nowadays, with the advent of new molecular diagnostic assays, we see a lot of cases of chlamydia. And the history is classical with the exposure of birds. The birds are the only primary reservoirs in this. And it has documented, chlamydia psittaci was documented almost 460 species of 30 bird orders, which is significantly high. Almost every bird or even the poultry is prone to get spread this psittacosis disease. And human beings, they get infection by inhalation of this dried feces from the caged bird wings in the house or feathered dust from that area, and visit to the bird park or bird sanctuarium. And the human to human transfer may occur rarely. We haven't seen a lot of those things. Rarely we do see. We have got exposed to the patient with chlamydia pneumonia with the but without a mask. But fortunately, less of us nobody got infected from those patients. And young and middle-aged adults are commonly seen, especially 30 to 40 years people we do see commonly getting this kind of bugs. These are some of the bugs, and commonly this is the budgies, we call that the lovebirds, which are commonly seen in a lot of the houses, and these are notorious to cause this bug. And the classical clinical features are fever and rigors. Fever and chills are very commonly seen with significant myalgias and headaches, same like a viral infection. and usually they get dry cough even after so much of mucolytics and also inducing sputum. We are even after day 3 also we don't get the sputum for these patients. Initially we try to give them time to get expectorated sputum, but unfortunately they don't give the sputum a lot. So early bronchoscopy is important if you are suspecting that your patient is immunocompromised, is getting worsened clinically. And breathlessness is one of the classical symptoms of chlamydia, and chest pain. Some people do have mild hemoptysis and pharyngitis and all those symptoms. GA symptoms also commonly seen, and altered mental status also seen in psittacosis and also in mycoplasma infections also. The diagnosis should be classical history of exposure to the birds, and incubation period is from 5 to 14 days, and immunofluorescence test is the good diagnosis where the 4 times elevated in antibodies are seen, and complement fixation tests also help us in identifying this chlamydia. The common blood test that we do is CBC and high CRPs, and LFTs there will be classical of AST on the higher side with the hyponatremias. And this is a case that we have admitted during the COVID time, almost 1 year back from now in the 2022. We admitted one patient with the history of the 42-year young guy with the fever, cough, and chest pain, severe myalgias and headaches, and he came with severe dehydration. On evaluation, we thought of COVID because there was a COVID going on everywhere. So we did basic CBC, CRP, waiting for the X-ray. The CRP was 400, so we all got shocked about but high WBC. So we thought something bacterial. So we have taken an X-ray chest, and we did a CRP. Creatinine was a higher side. Urea was significantly elevated because of the dehydration, and sodium was also low. Hyponatremia with procalcitonin 1.4, and saturation was 96, and he had mild tachypnea and tachycardias, and he was already given in other private setups ceftriaxone for 4 days, injectable form, but there was no improvement. He used to go and get IV fluid and paracetamol and come back home, but there was no relief. Then he was referred to our place, and we empirically we started him on beta lactams and also mucolytics, and also combination therapy with doxycycline after seeing this X-ray. This is the CT scan of that person. He got a bilateral pneumonia, but in this view, you can see only one side, right side pneumonia, significant right side pneumonia there. Almost 70% of the lung got affected, and the left side also he got almost like 25% got affected. And I took the history, and he has given that recently 1 month back he bought 2 parrots, and one of them got sick and recently died. And he was handling that bird a lot because of the love and affection that he got, and unfortunately he got infected from them. After getting this history, immediately we started him on doxycycline, and he responded very well. And we did routine testing for atypical pneumonia. On the day 1, we saw the chlamydia was identified. After 2 days, after 1 day, we got the report. We got chlamydia pneumonia, which was identified, and he responded very well. Within 2 days, we de-escalated. We stopped piperacillin tazobactam. We have gone with the monotherapy with doxycycline. He improved faster, and we discharged him home fast. And the treatment, the first drug of choice is tetracycline. Doxy is the common drug we use, and second comes macrolides and fluoroquinolones. The prevention from these bugs are, especially chlamydia, psittacosis, is first thing is try to stay away from the birds. And if at all somebody is willing to keep the birds at home, not listening, then ask them to wear mask and gloves while cleaning the cages, and use disinfectant as frequently, as these bacteria can live for months in the shaded feathers of that, and avoid breathing any dust from the dried bird droppings and feathers and cage dust. Always suggest to keep the birds outside, not inside the apartments. Try to keep, if there is a villa, try to keep them outside the garden. And take sick birds to the veterinarian. Isolate them. Don't keep in the house. And keep birds in well ventilated area. Okay, that's the way we can prevent this one. Thank you for your patient listening, and we are coming in the future with the new slides, with the new presentations also. Thanks a lot.